your presence. It's very good to be with all of you in this webinar. And I would like to thank all the guest speakers for giving us the chance to welcome them and to be with them in this webinar. And we would like to thank the organizing company and all organizing members. That this webinar wouldn't be possible without the effort and of all organizing members and all members in the College of Nursing and all guest speakers. Before we start with our webinar, I would like to introduce Dr. Mayer Rashid, the Dean of Nursing College, and she will give a short speech. This webinar will talk about the nursing practice during COVID pandemic, and every guest speaker was chosen because we need to learn from others, and we need to share the experience of nurses and how can we help the nurses who are in the front line to protect themselves and to learn from others' experience. So the program will be for 1.5 hours. And we'll start with our international guest speakers, Dr. Walter Di Caro from Italy, and then Dr. Alison Norfel from the States, and Dr. Mohammed Al Ghamdi from Saudi Arabia. Please, for all our audience, use the hashtag to share your questions or thoughts so we can share it and we can ask questions for our guest speakers. Sorry, but maybe Dr. May has a technical problem, so we'll wait for her presence. Dr. May is here and she will start her speech.
Yeah, good afternoon, ladies and gentlemen. It is my great pleasure to welcome you to the international webinar that discussed the impact of COVID-19 pandemic on nursing practice. We are very grateful for the organizing committee, international speakers, and our local speakers and guests. Nurses and healthcare workers face ongoing major challenges during the current COVID-19 pandemic, and it is an unprecedented difficult time in our life. From nursing perspective, we have to stand strong, protecting ourselves first and providing the best optimal care to our patient during this crisis. This important webinar in this critical time is aimed to provide the best current nursing practice during this pandemic. Moreover, how can we deliver the best nursing education and science without disruption and protecting all learners and educators? The College of Nursing at King Saud University in Riyadh is welcoming you all for this webinar. Thank you, Dr. Miller.
Now we'll proceed with our first speaker, Dr. Walter Di Caro. Dr. Walter Di Caro is the president of CNIA, Italian Nurses Association, and Nursing Now Italy Group. He's adjunct professor in nursing at University of Spezia and University of Rome Tor Vergata. He has completed his master's degree in business administration and management of health service, and he has a master in social research, data mining from University of Rome, and PhD in nursing science. Please join me to welcome Dr. Di Caro to share the experience of Italian nurses during COVID-19 pandemic.
Good afternoon, and thank you for this opportunity to share. I try to take my presentation. You see my presentation? Okay. Yeah. Okay. This afternoon I try to speak about our situation in Italy, and this is the outline of this work, more or less. You have some data about COVID in Italy, the new organization of health, issue about nurse and other health professional, priority and lesson learned, and some reflection. About COVID-19 in Italy, all start in 30 of January. At the end of January, we have the first 2 Chinese cases. But the real issue, the real outbreak start in 9 March in Italy. We have the total lockdown. Now we stay in, and these lockdowns finish on 4 May. We have more or less 60 days of total lockdown of the country. About the data, sorry. About data, we have in this moment about 25,000 people that died, and about 200,000 people positive. This is the data about the age. About 60% of people have more than 60 years, and this is an interest topic about. Now, in this moment today, we have 25,000 people in the hospital. Of these, 2,600 more or less stay in intensive care unit in EQ, and this is the problem. Yesterday we have new people in intensive care unit, and they have at least more or less 600 people that died yesterday. This is the situation. About all the situation, only 2% of people that has tested as positive stay in intensive care unit. About reorganization, government decide to move in 3 levels. We have a national level, a regional level, and a local level, and this is the hospital. At the national level, we have a task force that stay with the Minister of Health, Minister of Defense, and some other institute, like Protection Civil department. At regional level, the government stay with the assessor of health, and the hospital level change some organization. About the organization in the hospital, that this is our focus, the organization in the hospital and the health personnel. For the hospital, about the government decided they have 2 different movement. We have COVID hospital and COVID hospital. Some hospital is only for COVID-19 patients. At the same time, we have a field hospital, pre-triage tents that I show you after, and some possibility to swaps to test COVID-19 outside in the street. For professional, we have a serious, dramatic problems about shortage of health professional, in particularly nurse specialist in intensive care and anesthesiologist. During this this day of lockdown, we recruit all of nurse from retired military nurse, and we have also international aid from China, Russia, Germany, Albania, Norwegia, a lot of countries, also from Southeast. This is an image of pre-triage tent outside of emergency department. There is this tent only for COVID patients, for people that have some problems, people that have a fever or some symptoms of COVID have to follow with this area. Other issue is related to hospital bed reorganization. We have closed about all traditional activities. No, all surgery that can postpone is postponed. And about all hospital that is COVID hospital, reconvert all beds in COVID for COVID patients in two level. Intensive care beds and pneumology and infective care beds. About this is a number of this reconversion. We pass from more or less 5,000 bed of intensive care to more or less 10,000 beds in intensive care unit. And we pass from 6,000 bed in pneumology to 34,000. And this is for explain you that all the country is affected of these problems. Also, we have a special transport for emergency, air transport. Italy have a capacity for highly infection patients isolation with airplane. This is a military capacity. The airplane is sharing three areas. We have the area for patients with COVID, the area for health professional, and the green area is only for pilots. These other field hospital in the north of Italy, because we have a lot of patients and we don't have beds for these patients. And in some place we have this crucial role in also in field hospital. Another problem is related to the nursing home or the place for elderly people. In this place, about all the old people are affected by COVID. More thousand and thousand of older people died in this area. Why? Because in the first day of this outbreak, with PPE, personal protection equipment, and there is more or less not a real concentration, attention about this. Now, in this day in Rome, in my city, we have discovered a new nursing home with about 150 people that is positive, 30 healthcare workers positive, and already 10 patients died yesterday. This is some issues that I think is useful for other country. Until now, we have a general lack of personal protective equipment, especially in some situation. In the first day, there are not enough masks, gloves, and other PPE, especially for the community. In the hospital, more or less, the situation is okay, but for the nurses that work in the community, for the doctors in the community, there are some problems. And we have also some confusion in the first day of outbreak. At the start of this outbreak, in the first day, the first 20 days of March, there is not a real comprehension of this phenomena. This is some words about of nurses that stay in front line. Some nurses in front line that said me that they feel like they are going in a battle with paper shield and with toy guns, because there is necessity of these supplies, there is necessity of ventilators, and there is necessity of equipment. Also, some nurses that work in EQ said that stay in continuum roller coaster rides. This is anger, fear, sometimes joy because people stay well. There is a real new situation. This is an example of what happened. In 50 days, we have new healthcare workers. We have 20,000 new healthcare workers. Government decide to assume more or less 10,000 nurses, 5,000 doctors, and 6,000 healthcare support workers. But Italy have a shortage more or less of 50,000 nurses. Is a real problem for us. Government decide, it is an example of built a new task force that is a number, more or less 500 nurses, 500 doctors that move in all Italy for help some hospital that stay in, that have more issues, that can move from Milan to Venice to other city for help. Other problems is for a long time until now, more or less, there is a long waiting list for healthcare workers test swabs and there are a lot of difference in the country. There is some, I want to show you before this, because until now we have more or less 18,000 healthcare workers that are positive, 18,000. About 10% of people in our country that is positive is an healthcare workers. Of these, more or less, we have 10,000 nurses that are positive, and we have, as you see, more than 200 healthcare workers that die. Of this, we have 34 nurses and 142 doctors. About the doctors, this is doctors that stay in the community, the general practitioner doctors that in the first day of this outbreak work without personal protective equipment, without mask, without gloves, and work in contact with older people. And there is a spread of this outbreak. This is our priority for, this is a priority not only for nurses, but for the health system. There is a necessity of a clear planning, a control line, a plan. There is necessity of a coordinated action with doctors and with nurses at the same time, and a staffing for mitigate the risk, because without adequate staffing, there is now, and I show you after, problem of disorder, psychological disorder, distress, post-traumatic disorder, because nurses that work every day for days and days with in intensive care unit with a different shift of more hour have some problems. There is necessity of training of nurses to wear new protective equipment and to manage new symptoms. Also, there is a necessity of a preparation to overload activities. About all the hospital in north of Italy have to expand the intensive care unit and the pneumology unit, and all the nurses that work in education move to clinical area. All the nurses that are retired move to the clinical area, and we decide to for the student to finish their study some months before for enter in the practice. Also, is necessity extend swaps for test positive of all health professional immediately, and the government after ICN and the European Federation of Nurses lobby decide to do this. Also, other problem is related to the community care. Community care is crucial. We have some problem, some issue in community care in the north of Italy, because it's crucial for test, for isolation, and for home-based care. Sometimes it's better that the people stay at home and have assistance at home that stay in the hospital. Other things is for nurses particularly, is necessity to refreshing training about the virus and about tracheal intubation on the diffusion of infection, and in Italy start with some e-learning course and training in the hospital about this. Other things is the necessity of ventilator and intensive care bed. And this is the number of before. This is it's a dramatic situation. And also is dramatic for the nurse. Respect other health professional. We have 2 nurses that suicide. This nurse is tested as positive and work in a COVID department. These nurses have a fear, work a lot, work for a lot of shift, and they have fear to spread the infection to the other, to the family. And this is a real problem. We have to pay attention for stress and exhaustion. We have to pay attention to the psychological assistance. Now we start in Italy with some numbers, some psychological assistance in the hospital, because it's crucial give mental health support, not only for these days, but only for the next months. Also, we have some ethical issues, especially in the north of country, in the north of Italy. There is not enough bed for the people, for the older people, and the anesthesiologist and also the nurse that the bed manager decide who candidate for resuscitation and people that is not candidated, are not candidated for the resuscitation. And this is a real ethical issues, because if we don't have enough bed, we have to decide. And this is a different form of triage, and this is a real problem, because the people that are not candidate for resuscitation go to palliative care and probably died. Yeah. Also, this is more or less for someone is a positive aspect. There is a crucial attention of media, of newspaper, about nurse and healthcare workers that is described as hero, but we as nurse, we are all professionals. We show our sacrifice not only during this COVID-19 outbreak, but every day. I think this is the moment for us to ask the government resource and other things like new nurse for the patients for resolve our shortage. and this is some reflection about that is some problems in Italy is related to the political choice because we have an economical crisis. We reduce our bed from more than 300,000 to 200,000 beds in the hospital in 20 years, more or less. We reduce a lot of intensive care bed. And also for the nurses, all the contract in this moment is temporary contract. Government decide to have this new nurse only for 1 year, not for more, only for the outbreak. At the same time, in this situation, as lesson learned, there is a real growing approach related to the necessity of chief nursing officer at the government and regional level. We have also some problem related to the competencies, especially specialistic competencies for intensive care, because we move people from education or geriatric department to pneumology or intensive care, and this nurse is do not have the real competencies for work at the highest level that is required now. And this is some photo of my colleague. I have some colleague now that is tested as positive. Some stay in the hospital, some in intensive care, some stay in home care. We have this problem of personal protective equipment in the first days of the outbreak is a real problem. Other problem is that we don't have enough bed in a specific area, because in other area of country, like southern Italy, there is no real problem, because we mitigate the infection. But in the northern part of Italy, the infection until now is not controlled, is over control. And we think virologists say that the number is not real 200,000 positive. The virologists said more or less we have more than 1 million of people that is positive, because the problem is how test these people because we don't test a lot of people in the first 30 days. And now we hope to pass the peak. Government decided to start at the first week of May a new phases to open something, but until the end of year, I think the university is closed, school permanent closed, and restaurant closed, and now for people is about impossible move. We can move only for food shop, more or less, only for food. And the people that work more or less is only the healthcare workers as me, as you, and this is the situation. We hope that this situation passes, and we hope that there is a new spring for nurse. Thank you for the opportunity, Mrs. Monira, and thank you for the opportunity to Saudi Arabia for this opportunity to share. Thank you.
Thanks, Dr. Walter, for this great presentation. I think what's happening in Italy will be a good lesson for us and will help us to be prepared for COVID-19 and how we protect the nurses. It's shocking to know how much the nurses are suffering there. And I think this is what we need to do, is to support the nurses in the front line. Our second guest speaker is Dr. Alison Norfolk. Dr. Alison Norfolk is a PhD prepared nurse practitioner with expertise in novel care delivery models, clinician burnout, and role of nurses within interprofessional team. Dr. Norfolk is currently an associate research scientist at Columbia University College of Nursing in New York, and she is a fellow in the New York Academy of Medicine, a founding co-chair of the Health Services Research Interest Group at the Eastern Nursing Research Society, and a member of Sigma Theta Tau International. She also is on the advisory committee for Academy Health Interdisciplinary Research Group on nursing issues. And she will share with us her the experience of nurses in the USA. Welcome, Dr. Alison.
Thank you so much. I'm going to switch over to my screen. Okay. Thank you, Dr. DeCaro, for sharing your experiences in Italy. And as I'm sitting here listening to you, I can definitely hear a lot of similarities about our experience here in New York and across many areas of the United States as well. I just want to disclose that the views and content of my presentation are not necessarily representative of my organization or any government entity. So today I'm going to provide an overview of kind of the evolving role of US nurses and what has changed in our infrastructure and in our process and our teams. I'll give a little bit more detail about policy changes, both at the national level, but also at each individual state level. Talk a little bit about academics and nursing education, the role of the nurse scientist, as well as some very important emerging evidence about nursing health and well-being. So these COVID-19 statistics for the entire United States were current as of yesterday. And then I pulled up more current results as of this morning. And the United States has a total of 826,000 cases right now with 45,000 deaths. And this is across all 50 states, including some of our other jurisdictions. And you can see geographically, this kind of epicenter, although our first cases in the United States started in Washington State, the numbers have tremendously increased in the Northeast region, and this is where New York is located. Here in New York itself, our first patient was confirmed on March 1st, just north of the city. We have to date conducted almost 650,000 tests, and of those tests we have just over 250,000 confirmed cases. In New York City alone, we have almost 15,000 deaths, which is an increase of confirmed cases by about 4,000 each day. So you can imagine nursing practice has changed tremendously in a very short amount of time, record-breaking time. And it has been a lot of preparation on administrative side, but also a lot of trial and error as well, as we learned from our colleagues across the globe on how to best respond to this COVID pandemic. In a professional team-wise, the role of nurses within teams pretty much probably stayed consistent. We have nurses working in ICUs and across hospital units, as well as in the community, especially in nursing homes. But the workflow and process is what has changed. A lot of the workflow and process has been targeting nursing safety and healthcare workforce safety, as well as decreased transmission within the community. We also have a change in our targeted diagnoses. Much of our hospitals, especially in the New York region, have converted to COVID-specific hospitals. A lot of our outpatient care is now through telehealth and virtual visits, but predominantly in my county alone, which I am right outside New York City, I believe all of our hospitals are now COVID only. And one of the process changes that nurses are experiencing are redeployment. So nurses that traditionally work in different disciplines such as cardiology or surgical settings or community settings are being redeployed based on where the need is. And that especially with an increase of the need for intensive care nurses. Nurses that otherwise have not worked in intensive care are being trained on the job. So we are shifting nurses across hospital settings and across the community and testing sites to meet the volume for patient care. We also had a large call in New York State alone for retired healthcare workforce to come out of retirement and to help with our efforts and our response to the COVID pandemic. In the community and telehealth has focused a lot on chronic disease care, because outside of this COVID pandemic, we still have a large population with cardiovascular disease and diabetes and pulmonary and asthma related conditions. These patients still required maintenance and follow-up and medication management. And a lot of nurses are performing virtual visits right now to manage symptoms, to manage medications and refill of prescriptions, and also to answer any questions that patients or their family caregivers have. There is a lot of coordination going on across healthcare settings right now. We have opened public health testing sites as well. We have drive-through testing sites. The process in place right now is there is a public hotline where you call, and it's staffed by healthcare workers, including nurses, that have an eligibility criteria to see whether or not the general public meets the eligibility for testing. It is usually by appointment only, and then they get an appointment card, and then they'll be able to drive to one of the testing sites. And I also want to make mention, we have also really leveraged the use of a lot of volunteers, and this includes student nurses, graduate students across multiple universities, and non-clinical administrative staff. We had put a call out at the state level, at the university level, for large numbers of volunteers to help in any way possible, whether that is triaging patients, filling out paperwork, just directing patients across the process of getting testing, answering phones, and helping to coordinate care across settings. So it's just a tremendous outpouring of support from volunteers. Some of our volunteers also are on site to distribute PPEs when healthcare workforce are showing up at institutions that they might not necessarily work at in their primary position. We do have a lot of volunteers from other states outside of New York that have graciously come to help us with our response. Now, I think one of the more interesting aspects related to nursing is the extremely fast-paced shift in policy, nursing policy that impacts nursing practice and scope of practice, both at the federal and state level. One of the bigger things is traditionally a registered nursing license is maintained by each individual US state. You are licensed in the state in which you work in. And as a response to the COVID, several governors have basically suspended this policy right now to be able to grant nurses from other states to come in and practice within New York. So they are suspending cross-state restrictions to secure workforce in areas of need. Some other policies shaping nursing practice. At the federal level, we've had some changes in visiting nursing services to really expand nursing services in areas where there's a shortage of home health agencies. And a lot of this is in our rural populations that don't have as much access to care. We've expanded virtual communication services and includes non-face-to-face patient initiatives that otherwise would have been provided in the office and required an in-person visit. We've been doing a lot of physiologic monitoring, and nurses have been increasing their monitoring under the general supervision by the billing practitioner or the billing provider. We also have changed some policy related to the management and maintenance and detoxification treatment protocols for opioid use disorders. Traditionally, it requires an in-person or a telemedicine evaluation, and now we're able to do evaluations over the phone. Also, we have some generally requirement pre-COVID that nurses and need to perform on-site visits every 2 weeks in home health and hospice. And that also is temporarily waived this requirement for. And then finally, there's been a lot of changes with scope of practice, especially for our advanced practice nurses, such as nurse practitioners and our nurse anesthetists. The CRNAs require physician supervision, and this has temporarily been waived as well. Regarding nurse practitioners, and as you know, nurse practitioners are masters prepared or higher with advanced training and expanded scope of practice. Traditionally in the US states, each state, there is large variability in what a nurse practitioner can do within their practice related to consults with patients, prescriptive privileges, and each state basically defines what a nurse practitioner can and cannot do. Well, several US states have gone ahead and suspended physician oversight immediately to help increase the workforce supply for the COVID response. And this is allowing nurse practitioners to practice to their highest level of education and training without restrictive policy. At the organizational and local policy, every hospital, private or public, has their own local policy as part of the response. And some of the policies that I think that are influencing nurses the most and having the greatest impact on nurses are organizational policies related to visitors for patients and PPE requirements. Now, visitors to patients, not having the family members being able to be present for good reason to avoid transmission and increase transmission to the community. But this places a large responsibility on nurses to be the patient advocate, along with their physician and other healthcare worker colleagues. There is a lot of coordination to keep family members informed, having connections and having virtual visits with their loved ones. It's taken a real emotional toll on nurses to be that mediator between the patient and their family outside the hospital. And also, of course, PPEs. There is generally a lack of personal protective equipment, I think, across globally right now. So each individual hospital seems to have put in place different specific requirements to the best of their ability to try to promote healthcare workforce safety. Some of our infrastructure changes, as I mentioned before, nurses are being shifted and deployed to different settings. Their existing settings are being restructured. For example, this is one of our regional hospitals. This is their parking lot where they were able to secure all available space for patient care. This is one of their tent settings where they were able to treat patients, the overflow of COVID patients. This is our soccer field at Columbia University, or a football field to the rest of the world. But this has now been converted into a large 250-bed field hospital in partnership with New York Presbyterian Hospital. This is one of the first collaborations between a private hospital and the US military. So this is being staffed by a lot of retired military medics and physicians and nurses. So this is a great example of a very unique partnership where different institutions and different organizations that otherwise would not be working together are coming together to manage the response. We also have ambulatory care clinics, nurse practitioners. One of our clinics is leading the community to help offset the emergency department volume and influx of patients. This is our cough and fever clinic. And the goal of this is to help manage symptoms, to perform testing in the community. They're also conducting some research where they're screening for convalescent screening to screen for antibodies in recovered COVID-19 patients. And other really supportive kind of public measures in nurses. We've had a lot of private hotels that have closed their doors to the public and have opened their arms to healthcare personnel that cannot otherwise stay at home, or any visiting healthcare providers that need to stay closer to the clinical setting or have concerns about transmitting COVID to their family members at home. We also have had some transportation and some hospital shuttles back and forth between hotels and clinical sites to try to alleviate some of the stress on nurses that are really have changed the way they're living and changed their home environment. In academics, in nursing education, as we all know, almost several institutions went remote. Classes are being moved online. We have shifted to virtual didactic lectures. There is a question about doing virtual clinical rotations because a lot of our clinical students need to do these in-person rotations to meet the requirements for nursing licensure. There's questions about increasing simulation. All exams right now are virtual. Licensing and board examinations, as far as I know, were put on hold until next month. So we are also waiting for another kind of resource of new nursing healthcare workforce to come into the clinical setting. And as I mentioned earlier, our nursing students have, many of them have graciously volunteered to help in any way they can in the clinical setting. Now, in regards to research and the nurse scientist role, some of the national funding mechanisms have become very flexible. A lot of our research is funded by the National Institute of Health. They have encouraged recipients to consult with their individual institutional review boards and institutions about additional measures to protect study participants and research staff. Much of our research has ramped down and been placed on hold or postponed. We're limiting study visits for safety and conducting any type of study visits virtually that we can, over the phone, via Zoom. We've arranged flexibilities for required laboratory testing or imaging needed to safely monitor, and basically canceling all gatherings of 50 people or more. We also have suspended unnecessary travel related to any conferences or any study dissemination in person. Another funding mechanism flexibility is there's been an increase in supplemental funding, both by foundations, but also by our National Institute of Health, so that researchers can apply for additional funding related to their existing studies that could potentially help with the COVID response in a timely manner. Now, the role of the nurse scientist, and I'm increasingly here, we know it takes a long time to publish and disseminate study findings, but I'm increasingly hearing more and more work being done by PhD and DNP prepared nurses. But there still is such a large need for evidence related to the COVID response, not just currently, but the aftermath of it. There is going to be a large need for health services and workforce related studies, the patient experience, and not only the patients, but the families and the caregivers within our populations, different health disparities, policy, what is the influence of policy, biomedical science. We have a lot of nurses doing genetic testing and bench science to help with the response. And then also implementation. So how can we very, in a timely manner, get our study results from the research setting into the clinical setting in an effective way? These are just some examples of some of the studies that my colleagues and I are performing. Dr. Sainfer Aliyu is down in Washington, D.C., and she is leading a large study about the lived experience of COVID-19 on hospitalized patients and healthcare workforce. I have another colleague who is a psychologist within our School of Nursing doing testing the mental health impact of COVID-19 on the general public. And then I am working, traditionally my research, even before COVID, was looking at the longitudinal impact of stress on physical and psychological health on nurses. So now I'm applying this knowledge and methodology in the COVID context. And then one of the more important things that I really want to stress and go over is the impact on nursing health and well-being, especially because this is my background in nursing research and something I'm very passionate about. We do know for all healthcare workforce that long-term stress, physiologically, emotional and physical stress have a negative impact on the heart and cardiovascular system. Stress has been shown to increase heart rate and blood pressure, but what we don't know is how is the acute stress that nurses are experiencing right now going to increase their cardiovascular risk, their nutritional risk, any changes in circadian rhythm or sleep, and then in the immediate time frame, the risk of contracting COVID. Our own healthcare workforce and COVID transmission roughly, and these numbers are very rough because not a lot of healthcare providers have been tested as of yet. We don't have, we're trying to do the best we can in confirming how many nurses have contracted COVID. Although right now we know that there's over 9,000 US healthcare workers, inclusive of nursing, that have contracted COVID-19. 55% of those healthcare workers believe that that exposure was in their clinical workplace. 90% did not require hospitalization. A lot are recovering at home, and that's one of the reasons why we don't necessarily know all of the outcomes, because a lot of people are in the community right now. Although 5% did require and have required intensive care, and 1/3 of those have died who are over the age of 65. Just yesterday, there was a demonstration in our national capital for increased protection and safety, and the nurses were standing with large pictures of those nurses that we have already lost. It was a very moving picture. Some of the preliminary research that is coming out right now, some early studies, is the sense of anxiety, early stages of depression, distress, insomnia. I will tell you that some of my own research, despite these acute feelings, it is really incredible how resilient nurses are and how determined they are. We don't know the long-term impact on nurses. That still remains unclear, and we need more evidence and longitudinal studies to follow nurses probably for the next few years. But I will say, in talking with these nurses, in getting into the clinical setting and conducting qualitative research, the nurses are so determined, and they really are standing in solidarity with each other. Some of the strategies to improve well-being that have been implemented here are support groups, both inpatient and in the community. A lot of, we started at my university a circle of care support group where anyone can come in and sign in and share any traumatic experience that they have had, to ask for advice and coping mechanisms. We've also changed some workflow to encourage on-site breaks, to be able to have a nurse turn to a colleague and say, I just need a moment to step away, and giving them that protected space outside of the immediate patient care area. And it could be within the hospital, it could be you know, in a break room, in a chapel, in a cafeteria, but just some type of protected space where a staff member can go and know that they are safe to take a break and to recuperate before returning to the patient care setting. Some of the other initiatives that hospitals are doing right now, are trying to promote positivity, celebrating daily goals, acknowledging daily progress, and working in solidarity across disciplines. And this picture on the right, it is an example of a local hospital. This is displayed in their lobby. So every healthcare worker that walks by this every day knows how many patients have been extubated, how many patients are going home. There has been a lot of videos circulating on social media and the internet showing celebrations of patients being discharged. And that has had such a positive impact on the feelings within nurses. And I think that we all need to acknowledge in the year 2020, this year was designated as the year of the nurse and the midwife across the globe. And I know that so many of us had celebrations planned, a lot of dissemination of research and awards and accolades, and a lot of those are going to be postponed right now. But my colleagues and I keep discussing that, you know, although the year of the nurse and the midwife celebrations have paused, this is still a time for the world to witness the contributions of the nursing profession. And I think they are. And I think that is really important to carry with us. We have very important contribution to make to the global population. And I find it extremely incredible how borders across the world, especially related to the nursing profession, have been lessened, and we're all standing in solidarity with each other across the globe in the nursing profession. So thank you so much.
Dr. Mira, if you unmute your mic.
Yep. Thanks, Dr. Allison, for this very great informative presentation. I think what you shared with us is very important for us in Saudi Arabia, and I'm sure in Italy too, and other nurses in the world. Yes, we need to support our nurses to move on and to fight the infection that we face right now. Our local speaker is Dr. Muhammad Al-Ghamdi. Dr. Muhammad Al-Ghamdi is the president of Saudi Nursing Association in Saudi Arabia, and he's the director of Nursing Affairs and Ministry of Health. He is now in the front line with other nurses facing and fighting COVID-19 pandemic in Saudi Arabia. Please join me to welcome Dr. Muhammad, who works for more than 24 years in nursing practice, and he got his master's degree in nursing administration from Jordanian University of Science and Technology, and he got his PhD in nursing leadership and healthcare innovation from University of San Diego in California. And he's with us right now to share the current challenges that we face in nursing practice during COVID-19 pandemic.
Yes, hi, everyone. I just want to make sure the voice is very clear to you all. Thank you so much. Thank you all for our international speakers for the great presentations and the great experience that we all living every moment in the world. And thank you for the organizing committee. Thank you for Dr. May and her great team for organizing this event. Actually, what I'm gonna share is it's all over the world. Nurses is experiencing every day. What make no differences at all in the burnout and the stress and the workload and all of these experience that we do, but this is our commitment as a nurses, specifically that this is our year. And I know that there were a huge plan to celebrate this year as a designated by the WHO executives to be the nursing and midwifery year. However, we will do it in different way. We will do it in the ground. We will do it for the sake of the world safety and health. And we will prove it in the ground, inshallah. So I will try to share with you our experience during the last almost 2.5 months. I don't know, it shows in front of you now?
Yes.
Okay, good. So I will just give a quick snapshot overview of nursing workforce in Saudi Arabia, as it's a huge challenge for the nursing workforce in Saudi Arabia, with only 40% of Saudis working in the field, with other colleagues from different countries, more than 35 countries working side by side in Saudi Arabia, fighting coronavirus. Healthcare system in Saudi Arabia is categorized as a national system and serving for more than 34 million population. We have a huge challenge in meeting the benchmark or the indicator, the international benchmark, which is ensuring more than 700 per 100,000 population, or 70 nurses per 10,000 population. And the graph shows the differences between countries in providing that sufficient number of nurses for 10,000 population. We are in the middle. We are trying to target 7 or 70 nurses per 10,000, not compared to UK, for example, United States or Japan or Switzerland, other countries. This is one of the things that we have in our country to achieve in our 2030 vision transformation. Here is just a quick comparison between Saudi and non-Saudi, national, and non-national nurses, national versus expats. National, which is the green one, this goes back from 2002 to 2019. Nationalizing the profession, it's a huge concern in the country, where it's currently the right of every nurse belongs to different country to leave because they want to serve their own country. So this is a huge challenge, and the growth from 21% national nurses to currently 40% is a great progress. Such a large reliance on expatriates nurses to care for mostly Saudi patients actually poses important issues such as language barrier, cultural barriers, because most of the nurses come from different cultural background, from different perspective, different race and cultures. So this cultural barriers might impact the quality of nursing care provided to the patients. Also, nurses and patient satisfaction that might affect, because I cannot communicate with the patient and with the way they like. So, for example, I was in the United States, not looking to making eye contact to mostly senior citizens or patients might consider respectful or respect. Compared to the Asian culture, no, you shouldn't keep an eye with a senior. You have to look down. So that's it's an example for the huge differences in even eye contact. Actually, that implies in the high voluntary turnover. The same thing that's going to impact nursing shortage as well. And the nursing shortage will lead to increased nursing workload, because the rest of the work that should nurse do and the good sufficient ratio, that will lift over the rest of the nurses. So again, you need to retain nurses. You need to recruit additional nurses to cover the gap. So there is a recruitment cost, and then you need to train them as well. They need to be in a language training course, orientation, rotation programs, all of these. It's a cost. Yes, we are non-profit organizations, but it doesn't mean that we don't have to pay attention toward the cost of our organizations. Again, increasing nursing errors. That's because of the shortage, and the shortage will lead to higher workload. Higher workload will lead to increased nursing errors, like pressure ulcers, patient falls, infections, so many now infections going on back and forth. So this is one of the factors that might imply. And we have experienced the like CLABSI, COUTI, all of these indicators impact our organizations because of the nursing shortage, medication errors, and documentation, errors as well. So what do we know about coronavirus? Actually, we know little. We have previous experience with corona MERS. We lost 45% of our patients during that period of time, 2013 to 2015. However, we fight the disease. We succeed with the WHO in fighting in our battle. This is, I think, completely different. What we are talking is a huge pandemic, and it's the biggest challenge of our time. The strength of spread and COVID-19, it's a huge difference. Makes a new challenge for humanity to prove that we have either we have the sufficient knowledge, science, technology, or simply we will be attacked, if not by the COVID-19 virus, by the economic impact as well. So Saudi Arabia has taken this battle seriously, and from the first, actually before the first outset of Corona, before March 2nd, which was the first announcement of the first case, the government banned foreign worshippers from performing Umrah, which is a religious performance for all Muslims. And that was crucial point of how serious we are in this pandemic. Also, Riyadh has taken a tough decisions, for the greater good by suspending all international flights early for 21 days, and then extended to the current day. Actually, such affirmative actions like these give Saudis confidence in their ability to fight the disease. Still, we have challenges, as I mentioned, nursing shortage. Nursing shortage, it's a global issue. It's not only a national issue. However, During the current pandemic, the nursing shortage became a major concern in the Ministry of Health and other healthcare sectors. And the number of confirmed cases actually escalated to impact also the front lines, either physicians, nurses, all health care workers. So with not sufficient number of nurses or healthcare workers, not sufficient number of PPEs, sufficient training, and all of these things, we expect that nurses also will be infected as well. So from the first day, the Eastern Province, because the Eastern Province located near to where one of our citizens illegally visited Iran and then affected, it was the first case. The Eastern Province reported 20%. So there should be an action to cover the shortage first. And we succeeded to have a rapid response team in our Ministry of Health. More than 1,000 nurses, competent, punctual nurses, prepared nurses for such crisis, actually for during the Hajj season, pilgrim seasons, or other disaster, also during the Southern War. All of these events made our nurses very awake and alert to respond to such event. So we covered the shortage for almost 200 nurses till the Eastern nurses, I mean the Eastern Province nurses located in that area, take control over the situation. And then we settled all of these nurses to have a national surge capacity plan, start from, we have only now 2,000, 10,000, almost 10,000 positive cases. We are ready for 33,000 depending on the current statistics and the current preparedness of our country. We have set indicators and actions, and each indicator should elevate the preparedness from level to level. We are from level 2, 3, up to level 5, ready to have more than 40,000 beds, also 82. 8,200, more than 8,200 in level 3 ICU beds. So each capacity, we should be prepared from your nursing perspective. So we have to make ourselves ready. I'm not talking about numbers only. I'm talking about the knowledge and skills that should nurse gain before escalating to each level. So the most problem we faced, actually the cross-infection. Cross-infection was for me, it's like a nightmare. I know some reports wrote about 20% or 15, like China outbreak, 15%, and Italy, 20%, and reports from Spain, 14% of nurses infected by communicating with the patients. Actually, we have 9%. Then that's ring a bell that we have to dive deep and see what the reason behind this. Nursing shortage is one of the major reasons. Actually, we found out that we have to look to the hand hygiene compliance from nurses, proper use of PPEs, for adequate PPE supplies. And as it's a new pandemic, we should consider lack of training. These I think one of the most important issues. However, we go farther to make sure that we have an adequate supplies of PPEs. Whether or not nurses are using the PPEs correctly. So we have to make sure no use of PPEs without confirming the head nurses that you have passed already the training course, which is only 2 days, knowledge base, online training, and the second day is it's clinical training. So then you can provide care to the patient. So protect yourself first, and then protect patient and your colleagues as well. I'm just emphasizing in this because I remember 2 months ago when the coronavirus continued spread over and over. We had more than 45 nurses from one region, 4 hospitals infected. We forced to quarantine more than 300 nurses. So that's because of, and you have to make sure about the not spreading further infection. So make sure that once you lose one patient, one nurse confirmed as a COVID positive case, you will lose direct contacts with more than 20 nurses. So for 2 weeks. So just imagine how the healthcare system will be paralyzed during that period of time. And then we found out that the problem is that we don't have a sufficient education and training for nurses to deal with such coronavirus, such a pandemic. Also, we prepared guidelines and national protocols of how to deal with COVID-19 related infection control. Also, competency adherence, as I mentioned, regarding nursing management for acute respiratory failure and mechanical ventilator. Measure hand hygiene, as I mentioned, compliance, which increased dramatically during the last 2 months. Also, we measure the attack rate among nurses, which we are monitoring every nurse that is either suspected or confirmed case, and with specific formula or methods of calculation that we know this is acceptable, not acceptable. So we are in the good range till now. Also monitoring nurse satisfaction, as Dr. Alison mentioned. We have very stressful situations, and keeping nurses or leaving nurses in front lines without measuring their satisfaction or the turnover rate or the burnout level, it will lead for another disaster, which is within our house. So measuring their burnout, satisfaction, and turnover rate, all of these indicators give you at least preparedness to react if such indicators gone high. So I think this is all what I have to present for you. And just as we all emphasizing every now and then, I have 2 messages for our society. Please stay home, or as we say, خليك بالبيت. This is the most thing you can do for us. 2, for our nurses in the front line, God make you in this position, and specifically in this year, to prove to the whole world that we are doing great job. So thank you so much for giving me the chance to have this wonderful speakers with me today. And thank you for Dr. May and her team for organizing the webinar. Thank you so much.
Thanks, Dr. Mohammed, for your presentation. And now we'll move to the questions from the audience. I'm just trying to track the questions in the hashtag. And one of the questions we received was, how do we post moral and strength of nurses worldwide during this difficult time or a difficult battle with COVID-19? The question, they didn't choose the speaker, so anyone can start to answer.
I think I could, something interesting that came out of one of the studies we're conducting now is the great impact of the internet and of social media. You know, normally in a research or a clinical environment, you know, we're so focused on providing evidence-based care and what is published in the literature. And in this short amount of time, so many nurses have come together on Twitter and Facebook to support each other. Nurses that are strangers from different hospitals all over the world, sharing what they're doing and how they're doing it, and showing a sense of solidarity. And I think nurses in general are resilient, but I think it's important for organizations to really understand what the needs of the nurses are, and then we can start to develop initiatives and continue initiatives that are working to really support the nurses.
Thanks, Dr. Allison. The question for you, Dr. Di Caro, is there any recommendation that for shifts hour, like how many hours the nurses are working per week?
Yeah.
To minimize their burnout and stress and...
Depends. Normally in Italy, a nurse work more or less 36, 38 hours. And they have a shift of more or less 8 hours. Now we don't have, we suspend the law about shift, and normally have a shift of 12 hours. Every 3-4 hours, there is a necessity to have some break, because the clothes, the suit, the mask is impossible to stay for 12 hours without. And now we try to give this 3, at least 4 12 hours shift in a week. We hope to return in normal situation in some weeks. There are some, but the real situation is in the first 20-30 days, all the nurses show, as said Alison before, a growing generosity, a growing commitment. In some nursing home, we have nurses that sleep in the nursing home for 1 month. We have one nursing home in Milan that in 1 month, all the nurses, all healthcare workers sleeping inside. And in this nursing home, there is no cases of COVID-19. There is the problem now is that after 2 months, 3 months, there is as Alison said before, as Mohammed said before, there is a problem of burnout, a problem of necessity of psychological assistance, because it's a physical problem now. There is not a real psychological problem. It's a physical exhaustion now.
And the second question is again for you, Dr. Di Caro. do you send nurses to their home? Like after they finish their shift, do they stay in the hospital or go to their home?
Depends from situation. As said Alison, we have some hotels, hotels that give for free some rooms, others that stay in the hospitals, near the hospitals, others that stay in the field hospital, have a special part of field hospital. A lot of people that work in COVID department stay separately from the family, because as a nurse, we have to protect our family and prefer stay in another place, stay in another house, or stay in the hotel, or stay in the hospital is better for the child, also for the parents, because a lot of older people that stay in Italy, we have a family connection, and not is a common that the older people stay with the child, or the grandmother, the grandfather stay in the same close with the family, and in this moment it's not possible.
The second question is for Dr. Allison. How did you face the shortage of PPE? We saw lots of pictures in Twitter and social media, seeing nurses wearing plastic garbage or things like that, and they were complaining from shortage of protective equipment. So how did you manage that? And is it still a problem in the States?
I mean, I think the general supply of PPEs across the entire country is not where we would have wanted it to be even before the pandemic. Initially, what organizations were doing were they were designating specific units as COVID units, and those units had, nurses wearing PPEs, but then nurses outside those COVID designated units within the same hospital did not have access to full PPEs. And that's where you start to see people having makeshift gowns. It was heartbreaking. And I too saw a lot of those images. And I know that one of the nurses or the nurse managers that passed away were within that hospital where the pictures were coming out of. I think organizations are doing the best job they can. I don't think that any nursing administrators out there are trying to keep PPEs. I know several of my administrative colleagues literally were spending 20 hours a day trying to secure protection for their nurses. And it's been a struggle and it's been hard. Some of the policies in place now is you have one designated mask, and that is what you use over, let's say, 2 or 3 days. And then you can change out your PPE if it becomes soiled or dirty. But PPEs have been really kind of the central focus on nursing safety and the lack of PPEs. And that is what, as you saw in the image, we have nurses protesting down in DC, in Washington, DC, about getting a better response to protecting our healthcare workers.
Okay. Dr. Muhammad, there is a question for you. You mentioned nursing shortage in Saudi Arabia. Are you planning to hire newly graduate nurses who are a nursing intern to fight against COVID-19 during this time? Or there is any strategies?
Actually, we have restricted to not escalate any one of these actions unless we have triggers proven that we are in the next level. So what you have mentioned, that having nursing interns or physician interns, this is one of the plans, but not the current, because as the indicators given now, and the triggers, we are in level 2 out of 5. So we still are okay concerning the sufficient number of nurses and physicians and RTs. However, we are not, no one expect what will happen tomorrow. However, we are trying our best to contain the current pandemic. This is all options. I think we start with Dr. May and the nursing deans to put it as one of the winning card. We have more than 3,500 nurses, interns, ready to work. And I think that this is a good question for Dr. DiCario and Alison about the internship. The internship in our country for most, not the most, all the nursing schools having 1 year after the 4 years of education. So 1 year is intern, 12 months of internship. Very rare of nursing schools adapt this long period of time. Still, this is in the ball with the nursing deans to accept what's this event, to have that long period of time. I think this is a good decision that might be made, and we're still working on it.
Another question for you, Dr. Muhammad. Are you preparing nurses to work in the ICU or critical care units? Is there any preparation, any courses available for them?
Actually, we have set a plan that the nurses working in less acuity level units that can support the critical care nurses. Then we will go to the lower level, like an OBD nurse or primary healthcare nurses that can support the ward nurses, like medical, surgical, or stable COVID-19 patients. And the last level that we are expecting from the new nurses, new grad nurses, or from even volunteers, is to work face-to-face with the COVID-19 patients. Actually, they might work in quarantine hostels, but not with critical ill patients, of course, for the sake of their safety and for the patient safety as well.
Question for you, Dr. DiCaro and Dr. Alison. What was the nurse-patient ratio in COVID-19 units?
Depends from department. Now, problem that in some situation, also in ICU, in intensive care, we have 4 bed for 1 nurses. We try in this situation because the work with COVID patients is a little bit heavy respect to other situation. We try to have 1 nurse for 2 bed. In some situation, if we have some volunteer, 1 bed, 1 nurse. But it's a real optimistic situation. Normally in Italy we have, depends from the situation, in a common situation, not now, from 6 bed, 1 nurse, more or less. And in other department, in nursing home, sometimes there is 12 bed or 16 bed, 1 nurse and 1 healthcare workers. Depends. In EQ now there is necessity of more nurse because COVID patients have necessity to mobilize sometimes, a lot of times, and there is a physical also situation and monitoring situation every moment. It's a very stronger situation, and we try to move all the nurses in intensive care.
And in the United States, well, in New York, I can speak, but you know, normally intensive care, especially if someone is not stable and intubated, generally it would be one-on-one, right? So one nurse for one patient, but possibly 2 to 1. But when things got the influx and the surge of all of these intubated patients, that staffing ratio changed drastically. And nurses, you know, there was, you know, definitely even on the units, the medical surgical units, the telemetry, cardiac telemetry units, there are intubated patients outside of the ICU as well. One example I can give you, and a lot of nurses that are getting sick and then go, you know, and then staying home, that decreases the amount of workforce supply we have as well. So one particular cardiac unit, I can give you an example, had on a normal non-COVID related day, we would have roughly 1 nurse for every 7 patients, maybe 8 patients. And then at the height of this, these nurses were taking care of close to 12 to 15 patients. Also in the nursing homes, more and more nurses were getting sick and staying home. And generally a nurse in a nursing home might take care of 12 patients, you know, anywhere from 8 to 12, depending on the organization. And they were taking care of upward of 20 to 25 patients. I think it has improved a bit as we've learned how to reallocate our workforce resources. So things that the clinical nurse does not necessarily have to be tasked with, that can be designated to someone else, even a non-clinical staff member. That has saved a lot of time, but staffing, as we know, RN staffing ratios definitely have an impact on patient outcomes and clinician outcomes.
A question for you, Dr. Allison. Tell us about the experience of NP, nursing practitioner, in leading nursing teams.
Mm-hmm.
Like, what's the role in leading nursing team?
Yep. So I'm actually a clinical nurse practitioner. I've been practicing as an NP, as we call them, for about 11 years. And I practice outside of my research institution in a private physician-owned clinical practice in the community. And I am an independent primary care provider. So I see patients, I manage their visits, I come up with their treatment plans, I prescribe. It's very similar to a general practitioner. And now in the state of New York, our state law says that nurse practitioners that have over a certain amount of practice hours after they graduate, I believe it's 3,600 practice hours, then you are free from physician oversight. So I practice independently with my own panel of patients. That is not always the case in different US states. Some US states have very restrictive scope of practice where nurse practitioners are extremely limited in certain medications they can prescribe, any controlled medications they can prescribe, and what patients they can see. In light of this COVID pandemic, what I was referring to is a lot of the states have very quickly alleviated or relaxed the scope of practice laws for nurse practitioners so that we could otherwise go out and see patients without the supervision of physicians. We do have nurse practitioner owned practices in New York. We also have a nurse practitioner led group, specifically at Columbia University, that is completely run and managed by nurse practitioners. And they are playing a huge role in trying to decrease the volume of patients going to the emergency department right now by doing a lot of the triage, a lot of the symptom management in their own practice.
Another question for you, Dr. Allison. What did you do with nurses who are working, for example, in medical surgical floors, epilepsy units, and outpatient to shift them to ICU or to COVID-19 units?
Yeah. So I can give you a very specific example. One of my cousins is a nurse in the operating room, And majority of our hospitals have stopped all surgeries unless it's a traumatic emergent situation. So because she traditionally spends her time in operating rooms and ambulatory surgery, that entire department was shut down. They took all of those nurses and they deployed them throughout other units on the hospital to help with different tasks, dependent on what their training and knowledge was. So nurses are not being asked or forced to doing things that they are not competent in or they do not demonstrate competency in, but they might be working alongside a nurse, an ICU nurse. They also have been given different roles as patient advocates, as following up with medications, administering medications that they are comfortable administering. So it's really, most organizations have utilized their workforce and assessed what their capacity was, and then based on that capacity, deployed them in the roles that they can fulfill.
The last two questions we have is for Dr. Muhammad. What psychological support that we have or strategies for nurses and healthcare workers in frontline?
I think it's very important that psychological support, emotional support, and either recognizing their job is very crucial point at this moment. Most of our nurses, they just want you to be supportive and to acknowledge their job, and that's their prize. Our organization, from the association perspectives, we have launched a huge campaign to recognize the nurses' job in all over the world, not only the nurses, or not specifically the national nurses, because what we do is for the sake of our humanity, and from humanistic approach, we are doing this. I think there's a huge package of looking to the scales and the allowances and rereading the whole packages that provided to the nurses. I'm not announcing anything yet, but this is very considered in the top level management and leadership.
And what about the incentives and salaries for nurses in
Yes.
Saudi Arabia and the States and Italy? Is there any plans to improve the salaries and the like the incentives that nurses are receiving right now?
About the salary question.
Yep.
That depends. We have a different situation. For the task force, the general task force is a national response team. For the general response team, government decide to give 200 euros a day of work. 200 euros a day. For the people, for the nurse that work in some region, depends from the region. One region decide that the people that nurse that work in front line, people that say in front line in COVID department or in intensive care, depends from more respect the useful respect the normal 1,000 euro a month, or in other situation more or less I remember 50 euros a day. But there are a lot of other nurses that work in the similar condition of before, like people like nurses that work in nursing home, because in Italy we have some different contract, temporary contract, people that work without rules and other that work with government, because we have a national health service. The people that work with national health service have a protection, and every region decide to improve the salary in this moment. For the others, the situation is not so simple in this moment. But we hope that all the nurses know the real problem is that Italian nurses earn the low pay of all Europe, more or less. We stay at the same level of Portugal and I think less than Spain. And a nurse that work in pre-shift a week, 36 hours a week, earn more or less 1,500 euros a month. 1,500 euros a month. That is a low pay in general.
No more questions, and now we'll come to the final remark. And we would like to thank all the guest speakers for accepting our invitation in a very short time, and for being with us now in this difficult time to share the experience and to help us as nurses and nurses in the front line to learn and to be ready for caring for COVID-19 patients. And on my behalf and behalf of all nursing faculty members and the Dean of Nursing College in King Saud University College of Nursing, we'd like to thank all guest speakers, all audience, and the collaboration of the College of Nursing and the Saudi Epilepsy Society to prepare for this event. And we have a special thanks for Even Troop for giving us the time and the technical support for almost 24 hours for the last few days. And I hope this webinar helped a lot of nurses, not just in Saudi Arabia, not just in the States or in Italy, to be prepared and to have a better knowledge on how to provide care for COVID-19 patients. Thanks everyone, and see you again in near future, and please stay safe. Bye everyone.
Thank you. Stay well, everyone.
Bye-bye.
Bye-bye.